Thank you so much for having me. My name is Ariana Meltzer Bruhn. I'm a fourth year medical student at the Perelman School of Medicine at the University of Pennsylvania. First off, I'd like to congratulate Dr. Matt Landrum, who is the recipient of this award. Very, very well deserved. He's a great doctor, mentor, co-researcher that I was very lucky to work with and learn from. I also would like to thank Dr. Keith Baldwin for the opportunity to work on this topic. As this is the last presentation of the day, I will do my best to keep it brief since I know I'm standing between you all and kind of dinner, and so I will try to keep this brief. This presentation and our subsequent manuscript is entitled Nutrition Consult in the Year Leading Up to Neuromuscular Scoliosis Surgery, Helpful Tool or Self-Inflicted Wound. We have nothing to disclose. For some background, broadly, neuromuscular spinal deformity is a three-dimensional curvature of the spine caused by poor muscle control, spasticity, neurologic weakness, or paralysis. Neuromuscular scoliosis typically worsens as a child grows and can cause damaging effects on sitting, balance, skin breakdown, and overall quality of life. Scoliosis can both present in the ambulatory and non-ambulatory neuromuscular patient populations. Surgical treatment of choice for neuromuscular scoliosis entails posterior spinal fusion with segmental instrumentation. This treatment is an accepted method of management for the deformity, but surgery can be associated with a high rate of complications, things like infection, prominent hardware, and/or pseudoarthritis. Posterior spinal fusion is undertaken with the goal of preventing some of the effects previously mentioned and to maintain sitting ability, prevent future pulmonary dysfunction, and improve quality of life. We know that patients with neuromuscular scoliosis who are undergoing posterior instrumented spinal fusion can be underweight, malnourished, and have higher complication rates. For example, a BMI of less than 20% on CP growth charts has an increased risk of mortality. Therefore, the practice of obtaining a nutrition consult for weight optimization prior to surgery for scoliosis and neuromuscular populations is common. Previous studies noting weight gain following PSF have been criticized since many of these patients receive nutrition consults and management prior to surgery. While weight gain may result from ongoing nutrition management rather than the surgical intervention, anecdotally, we have observed that significant curve progression may occur during the period of time in which nutritional interventions are being implemented to optimize the patient for surgery. We wondered if these nutrition consultations were helpful. So the purpose of this study was to determine if nutrition consultation in the year prior to spinal fusion resulted in significant differences in weight gain or percentile on the CP growth chart. Our secondary aim was to determine if there would be deformity progression during that time. For our methods, this study was an IRB-approved retrospective chart and radiograph review of all patients with neuromuscular spinal deformity treated with posterior spinal fusion at CHOP between January 1st, 2009 and August 1st, 2015. Our inclusion criteria is seen here, where patients were less than 20 years old, had a diagnosis of neuromuscular scoliosis, and had 1 year preoperative percentile on the CP growth chart of less than 50%. Patients were excluded if their original PSF was not done at CHOP, if it was a revision surgery, or if there was insufficient data for us to review. Patient demographics, GM-FCS level, weight percentile, and appropriate CP growth chart, major curve, and pelvic obliquity at 1 year pre-op and at surgery were recorded. We used the CP growth chart as a large percentage of the population had CP, and to my knowledge, nothing specific exists for neuromuscular scoliosis at this time. We considered a nutrition consult to be an appointment with a gastroenterologist, a registered dietitian, or pediatrician within the Office of Nutrition 1 year preoperatively. The patient was required to attend at least one visit with a nutrition supporter to be considered evidence of a nutrition consult. In our study, we started with 445 patients undergoing posterior spinal fusion, with 329 of them qualifying as neuromuscular scoliosis patients. 68 of those met inclusion criteria. Of those, 37 had nutrition consults, where 31 did not. There were no differences in gender or age. However, there were more tube-fed patients in the nutrition consult group and more ambulatory patients in the non-consult group. If I can get it to move to the next slide, there we go. So for our results, for all comers, there were significant differences in weight gain, percentile gain on the CP growth chart, Cobb angle increase, and pelvic obliquity increase. When we looked between the groups, there were no significant differences between the nutrition consult group and non-consult group when it came to weight, CP growth chart, percentile, or deformity. For some additional findings, we found that it was an overall average increase in the preoperative albumin value, but that it was not significant. After adjusting for tube feeding and ambulatory status on a multivariate linear regression, no differences were observed between the nutrition group and the non-nutrition group for percentile gain on percentile weight gain in the year leading up to surgery. Interestingly, the only significant independent predictor of weight gain in the year leading up to surgery was the presence or absence of a feeding tube. Children who were tube-fed gained on average 10.8 percentiles in the CP growth chart, whereas children without gained only 0.5 percentiles. This was significant. Something additional that was not the main focus of our study and is not currently noted on the slide, but there was also no significant difference in post-op complication rates between patients who received a nutrition consult and those did not. Some of the complications we saw were wound problems, GI bleeds, pressure sores, prominent hardware, and fevers. So for conclusions, we did not find evidence on multivariate analysis after controlling for other factors that nutrition consultations in the year leading up to surgery improve weight as measured by percentile in the CP growth chart. This supports our hypothesis that nutrition consultations in the year preceding surgery do not lead to weight optimization in comparison to patients without nutrition consults. This does not mean to show that nutrition consults are not valuable in a patient's overall care. It just raises the question of timing. If there's concern for a child's weight or nutritional status, it's important to request a nutrition consult ASAP. As we've seen, delaying surgery can lead to a worse deformity for a child, decrease the possible correction, potentially decreasing their quality of life. Finally, G-tubes were found to be helpful for weight optimization and are something to be potentially considered in the future for this patient population. It can be argued that these patients had ongoing nutritional management and hence had longer exposure to the intervention. In children with CP, prior research has shown that placement of gastrostomy tubes has led to significant improvements in the children's health, weight gain, and nutritional status. So it stands to reason that in patients with feeding tubes, it's easier to increase food delivery than in patients without. It's easier to dial up, dial down, kind of change the nutritional mix of what the child is being given. So based on this idea, consultation for placement of a feeding tube upon identification of neuromuscular scoliosis in underweight children may be warranted. Based on these findings, we propose that nutrition consultations may be of use as long as they are initiated with enough time prior to surgery to enact meaningful weight gain and do not cause a prolonged delay resulting in a more substantial and potentially perilous deformity to correct. In addition, we propose including a discussion of alternative nutrition options such as G-tube placement or supplemental enteric nutrition in pre-op planning. These consultations should be pursued by the orthopedic surgeon as soon as the patient is identified as being low percentile in the CP growth chart and not wait to consult when surgery is indicated. Our references can be seen over the next 2 slides. Thank you again to Drs. Landrum and Baldwin for their hard work on this project. And thank you all so much for listening to the presentation and giving me the opportunity to speak today. Happy to take any questions or comments.